We're good.
There we go. I do
Okay.
apologize. I didn't
No
realize
worries.
it would mute you as well.
This is good. Don't talk. All right. So I'm going to start again. How many people do we have?
We have 13 right now.
All right. Small group. All right. So I'm Cindy Yoshida. I am a gastroenterologist at UVA. And for many of you, I work out with you at classes at ACAC. And for some of you, I do your colonoscopies because we live in such a small community. But really, why are we doing this month? It's because March is Colon Cancer Awareness Month, and Angela has really been kind enough to allow us to come really share the message that screening saves lives. I think it's really important for us to get the word out that colon cancer is preventable and it's treatable and it's beatable if we do colorectal cancer screening. So we want to make sure that everybody understands what screening options are available to you and why it's important to get screened. So just so that we're all on the same page when we're starting, I wanted to start with a little bit of the basics about what is the colon. And really, the colon is your large intestine. It's the same thing. So when we eat food, food goes down our mouth into our esophagus, which is our swallowing tube, into the stomach, goes into about 23 feet of small intestine. And that's where all the major action happens. So all the food is broken down and it's absorbed in the small intestine. So once it gets through that 23 feet of small intestine, it actually gets into the what's left, which is not much. It's mostly just gastric acid, a lot of enzymes, and which is very liquidy, and then whatever was not able to be digested, so the waste. And it gets emptied out into this from the small intestine into the colon. And the colon is here. You can see that here's the small intestine emptying in. The colon's broken down to about 4 different areas, and it is about 6 feet long. So you have the the right colon here, the ascending colon, the transverse colon, what we call the left colon, which includes both the descending colon and the sigmoid. And this little part here is the rectum. So when we talk about colorectal cancer, this is the colo and this is the rectal cancer. So colorectal cancer involves can involve any place in the colon. It doesn't really spare any part, just like skin cancer can develop in any part of your skin. We have a large surface area in the colon, and so colon cancers can develop everywhere. What we know about the colon, what's the function of the colon? So everything that's left over, which is the waste, gets deposited here into the colon, but it's pretty liquidy, like I told you. So when the stool gets here in the right colon, it's mostly water. But by the time, it comes out here at the very end, for most of us, it's a log-formed stool. So as the stool transits from this part of the colon to this part of the colon, it's actually absorbing a lot of the water. So it's said that about 1.5 liters almost of water is absorbed from the colon almost every day. It's a lot. That's a lot of water. Otherwise, if we would lose that water, right, we'd become pretty dehydrated very fast. So colon's functions are to absorb water and to store waste. Get back to here. All right, so let's talk a little bit about colon cancer. So colon cancer really develops from the innermost lining of the colon. So if you look here, this is the inside wall of the colon. The colon is like a big tube. And so if you look at the inside lining of the colon, the cancers start in the very innermost lining of the wall of the colon. And then over time, it grows into the wall of the colon, more into the wall of the colon, can go outside of the wall of the colon. And then when that happens, it can involve some lymph nodes outside. And then in the really worst stages, it can spread to further parts of the body. So it can go to the liver as a metastatic disease. So we don't like that to happen. So the thing about colon cancer is you might think, I hear about so many other cancers right now. It's kind of overwhelming when we watch TV, right? All the medications that we have for lung cancer, et cetera. But colon cancer really is pretty common. It's about 1 in 25 women, 1 in 23 men are going to get colon cancer. And it's the second leading cause of cancer deaths in men and women combined, second only to lung cancer. So you can see there's going to be a number of cases. And every time I diagnose somebody with a colon cancer, it's hard because I know that colon cancer could be preventable. And I think if people had screening, we would see a marked decline in these cases. The other thing about colon cancer is it's pretty expensive. So it's said by the American Cancer Society that if a person gets diagnosed with colon cancer, that it'll cost about $150,000, whereas screening is nowhere near that cost. So if you just can get screened, and you may think of screening as being potentially expensive, but if you can get screened, it's really worth your money to not get the ultimate bad thing of colon cancer. All right, let's go back to here. So what I hear oftentimes, a lot of times from patients is, I don't really need to get screened because I don't have any symptoms at all. But you could see from that slide that I showed you that most of these cancers start pretty early in the wall. And so they're not going to give you any symptoms. It's only when they become really pretty large that you're going to start to see bleeding or blockage of your stool. So it's going to take a while. And so it may be that if you wait for symptoms, you're probably going to be waiting too long before you get screened. So we don't want to wait. We're not talking, when we're talking about screening, we're not waiting until you get symptoms. We're trying to screen before you ever get symptoms of colon cancer to prevent it and to take it out. So let's talk about how colon cancers start. So the vast majority of colon cancers begin as colon polyps. And here's some example of some different polyps that we see. So up here on the left-hand corner, you can see these kind of polyps here. So this is a kind of a hill-shaped polyp. This is one that's kind of a mushroom-shaped polyp. These are called adenomas. These are the polyps that we saw very frequently. They happen more often in the left side of the colon. And again, if they grow big enough, they can turn into cancer. But you've probably heard in the last decade in the news about these flat polyps, which are down here. These are called sessile serrated polyps. They have very different pathways to getting to the different polyps, but they're both precancerous. These very flat polyps, you can see how incredibly subtle this polyp is. And this is using a little bit of blue dye. You can see the polyp here. So the thing about this is that these colon polyps, these flat ones, are more common in women, and they're more common in the right side of the colon. But both, as I said, can ultimately lead to colon cancer. All right, so colonoscopy is helpful, and it can save lives by, if we remove these polyps before they turn into cancer, we can prevent colon cancer deaths. So here, if we look at the polyps I showed you earlier, that most of these polyps start from very small little polyps, and they grow bigger and bigger over time. There's a number of genetic changes that happen in a polyp, and then ultimately they turn into cancer. What I can tell you is this whole pathway from the start of a polyp to the formation of a cancer, in most people, takes a long time. It takes about a decade, about 10 years. And what we know is that the vast majority of cancers, when they happen, also start at the very top of the polyps, and then they grow downward into the wall of the colon, and then ultimately outside of the wall of the colon. So if we have a polyp and we take the polyp out, we can prevent you from developing colon cancer. Even if you had early onset cancer and you had screening tests, we could find the polyp in this stage, take it out, and also cure your cancer by doing a colonoscopy. So it's not, when we're doing screening, we're hoping to find things kind of in this area and not get you to this. Oh, I wanted to say too, that if all of you guys have questions, I only have about 30 minutes of presentation. So I'm hoping that if you have questions, I am happy to answer any questions that you have at the end of this seminar. So does colorectal cancer screening save lives? And the answer is absolutely yes. But it does make an incredible difference. So Medicare started paying for colonoscopies in 1995 here. And so if we look at those who were Medicare eligible over the age of 65, you can see that when it really took about a decade for us to really ramp up colonoscopies. But by 2000, we were really doing a number of colonoscopies. A number of people were getting screened. And I don't know if you remember, but the American Cancer Society in 2014 also started a pitch called 80% in 2018, that they wanted 80% of the community to be screened by 2018. That was Katie Couric's pitch. She really went out to the public and said, because her husband, Jay Monahan, had died of colon cancer at a very young age, she really put out the pitch that people needed to be screened and we needed to get those screening levels up. So what we saw is that from 2000 on, that we actually halved the number of colon cancers in the United States just by doing screening. So we can make a difference. And I think, you know, we're not at 80% yet. We are in the state of Virginia, we're only 80%. I'm sorry, forgive me. In the state of Virginia, we're only at 70% of our population that's screened. And most of that population is over 65. And so we have a ways to go still. If we can get more people screened with colon cancer, we can definitely get this line to go further down and save even more lives from colon cancer. So that begs the question, when do we start screening? So, you know, it used to be that the magic age was 50. That was kind of the year that the AARP would send you all the stuff about being into retirement and getting older. But now the magic age is 45. And the United States Preventive Services Task Force is going to announce actually next month in April that this is official, that screening is going to begin at 45. So the insurance companies, it usually lags about 6 months, but insurance companies should begin to start paying for colon cancer screening for 45-year-olds, probably by early next year. We're seeing that happen. But I think it's really important to bring this about. Why did this happen? And I'll tell you later in the talk. The reason this happened is because we're seeing a really big increase in young onset colon cancer in people under the age of 50 getting colon cancer. And the vast majority of those people who are getting cancer are between the ages of 40 and 49. Why did we go to 45 instead of going to 40 for a screening age? It's because it's really still a small number of young people that are getting colon cancer. And really, if we look at screening across the nation, what we're seeing is that 65 and above year old people are getting colon cancer screening, but 50 to 59-year-olds are not getting screening. So we believe that if we can get our message out there to get people to start screening at 45, we'll get some to start at 45, but hopefully we can get a lot more in the 50 to 59-year-old age group to get screened. And, you know, I just diagnosed somebody yesterday with colon cancer. And like I said, it breaks my heart because if screening happens, that doesn't need to happen. We don't need to have colon cancer. All right, so, you know, you might think of colon cancer screening as only colonoscopy, and that is absolutely not true. There are a number of different screening tests that are out there, and so you and your doctor need to get together to decide which screening tests are absolutely the best for you. And if you look at these tests, they really are equivalent. It's not that colonoscopy is, you know, so much better. If you do these other tests on a regular basis, you can find these polyps and/or cancers, and we can prevent you from developing colon cancer as well. So let's talk about the tests. There's more tests than this that are available, but I'll tell you that these are the 3 tests that are most widely used in the United States. And rather than to bore you with things that are not often used, I thought I would talk about these 3 tests for the most part. So one is the fecal immunohistochemical test, the FIT test, which we would do every year. It's a stool-based test. Second is Cologuard, which we would do every 3 years. And this is a stool DNA test and a FIT test. And the third is colonoscopy. And we're going to talk about all of these tests at length so that you have an idea about really what they are and what they're doing. So remember, I showed you that slide earlier that when colon cancers start, they start at small sizes, and as they grow over time, what happens is that they can shed blood. They bleed microscopic amounts of blood. You might not necessarily see the blood in your stool, but there's microscopic amounts of blood in the stool. And they also, over time, shed cells, and those cells have DNA. So these 2 tests that are based in stool are tests that can check both for blood and DNA in the stool. So the FIT test here actually looks for human hemoglobin in the stool. So what you do is you talk to your doctor. Your doctor gives you this kit at home. You take it home. It's private, it's non-invasive, and you just take a sample of your stool and you send these little brushes back into the lab, and they check to see whether or not there's blood in the stool. The other test on the other side, the Cologuard test, you've probably seen these advertisements on TV. Cologuard does two things. It measures not only blood, similar to the FIT, but it also measures DNA. So there's microscopic amounts of DNA in the stool that are from these potential polyps or cancer. So the Cologuard team can actually find those little pieces of DNA. They can amplify them and make them bigger, and they can actually see whether or not you have either of the two, blood or DNA in the stool. The nice thing about these tests is that you don't have to take the colonoscopy prep. There's no dietary restrictions. You do this on your own time. And it's private, and you don't have to, go and have an invasive test as a colonoscopy. I think the really important thing is that some doctors even might try to convince you that colonoscopy is the only way and tell you that it's the best thing to do. But if you feel uncomfortable and you really don't want to have an invasive test, or you don't want to take this prep, this is definitely, these stool-based tests are definitely good screening tests that you should consider as an option for colon cancer screening. Now, it's important to remind you, just like all roads lead to Rome, if you have a positive FIT or a positive Cologuard, if there's blood in your stool, or if there's blood and or DNA in your stool, you have to have a colonoscopy. That's the completion of these screening tests. So if they are negative, then you're good for another year. And most people, about 90% of people who have a FIT test are negative. And you can just go on and have another screening test in the next year and the year after and the year after. But if a FIT test becomes positive, then that means there's something in the colon, and you probably should have a colonoscopy as a completion, usually within 6 months of having your FIT or your Cologuard test. So let's talk a little bit about colonoscopy, and this is what I do. So I think for you, I wanted to just make sure that you understand a little bit about what this test entails. So the other tests, the FIT test and the stool DNA test, are what we call detection tests, because they detect colon cancers or colon polyps. Colonoscopy is considered a prevention test, because not only can we see the polyps at the time that we're doing the test, but we can actually remove the polyps at the same time. So it can prevent the colon cancer at the same time. Now, I'm not going to lie to you, colonoscopy is not an easy take-it-home test. It requires a lot of work on your part and my part. We're a team in order to make this to be a successful exam. So really what this test is, we take a scope with a light and a camera, and you can see in the picture, and the scope is about 6 feet long, and we take the scope and we actually insert it into your colon, and we're looking, just like I showed you in the model, up the rectum, up the descending colon, transverse colon, all the way to the right colon, and oftentimes into the small intestine. But in order for us to see your colon, we have to give you that prep, right? So that prep is all this stuff at the bottom. And many of you and many patients really are most concerned, especially most women, are most concerned about the prep and how much they have to drink. I want to reassure you that in this day and age, there are a number of different preps out there. You don't have to take this 4-liter gallon of stuff anymore. So there are these lower volume preps that you can see here. There's something called Suprep. There's even a tablet-based prep. It's called Sutab. Now, these other more lower volume preps tend to be a little bit more expensive, but if the prep is the thing that's going to keep you from doing the colonoscopy, then you should consider asking for some of these other preps, because they definitely work as well. So the reason that a colonoscopy can be a little bit uncomfortable is because when we have to look into the colon, we have to put air in the colon. You can see normally when the colon is empty, it lays flat, kind of like an empty balloon or an empty tube. And so in order for us to see in all the nooks and crannies of the colon, we have to be able to insufflate the colon, usually with carbon dioxide. And carbon dioxide works well because in the olden days, we used to have air to insufflate the colon. And that was difficult because the only way air would pass was out the bottom. And so you had to, after you were done with your colonoscopy, most people had to expel that air. And so if you were in the recovery area, there was a lot of farting going on, right? But now, if we use carbon dioxide, that gas that's used to insufflate the colon is actually expelled and you exhale it. And so most people don't have any real problems with a lot of distension after a colonoscopy. So this distension, though, can cause some discomfort. And I tell women that it's oftentimes like labor pains when we're going up into the colon. When we come out, though, it tends to be less uncomfortable. It's almost like having a bowel movement. So most people often require sedation to have their colonoscopy. Again, because you're getting sedation, you're going to need to take your day off of work most often, and you're going to need somebody to drive you home. And that's a big deal. I mean, I understand that. It's not going to be like having a stool test and doing this in a couple of minutes at home. So, and colonoscopy is an extremely safe test, but any invasive test is not without risks. So there is risk of, people are most worried about perforation, which is poking a hole in the bowel. And that's probably the least likely thing that can happen. People are also worried about infection, but I want you to know that the way that we currently wash our scopes is really super labor intensive. Our scopes go through a hand washing by a tech, and then they go through a very detailed mechanical scope washing, almost like a dishwasher, and then they're hung to dry, and they have to be completely dry before they actually are used again. There's a lot of quality processes that go into scope washing, and it's really important that you know that when you go to have your colonoscopy at a certain site, that you go to a site that actually has good quality scope washing. And we do that at UVA. We are an ASGE recognized endoscopy unit. Which means that we have to follow certain parameters to make sure that the quality of our endoscopists are good, but also the quality of cleaning our colonoscopes is also very good. All right, so I talked to you a little bit about all the tests that are available. The one I didn't talk to you about is CT colonography. That's this CTC here. And CT colonography is a test that is available to have a CAT scan. It's not as good because it doesn't really see some of these flat polyps very well, but it is still something that is possible. But we only do only a handful of CT colonographies at UVA, even in a year. So who should get which test? If you are average risk, a man or a woman between the ages of 45 and 75, and I'll talk to you about high risk in a minute, then you can have any one of these tests. But if you have a higher risk, if you have a family history of colon cancer, if you have a family history of advanced colon polyps, if you've ever had colon cancer, or if you've ever had polyps, or if you've ever had inflammatory bowel disease, Crohn's disease, or ulcerative colitis, you should not be having the tests above. You should be having colonoscopy as your screening. And that's really important to understand. And that's why it's important to talk to your doctor about which test is best, because they can talk to you about your family history. And if your mom or your dad had an advanced polyp or had a colon cancer, then they would probably tell you that colonoscopy is your very best option. The only thing I'm going to say about this test is when we're looking at the screening tests that are here, you can see that colonoscopy is every 10 years, FIT is every year, and that stool DNA FIT or Cologuard test is every 3 years. And you can see if we look at what is the sensitivity, how good are these tests at finding colon cancers? And they really are pretty good at finding colon cancers. So I want you to feel comfortable that whether you do a stool-based test or a colonoscopy, that you can get good screening, and then looking at the costs too. The other thing I wanted to tell you about the Cologuard test, since many people are choosing that since it's advertised so highly, it's important to remember that the Cologuard test can have some false negatives in people over the age of, false positives in people over the age of 60. So that's many of us, right? Many people who are in the screening age. So a Cologuard test, because it looks for DNA in the stool, it looks at something called methylation of DNA or hypermethylation of DNA. What happens as we age, in normal aging, is that we can see that our normal cells in older people actually have hypermethylation. And so just normal cells that get into the colon, or normal colon cells that are hypermethylated due to aging, can get into the stool and can cause this Cologuard to have a false positive test. It doesn't happen often. It happens about 13% of the time. But I want you to remember that, because when you get a positive stool study test, a Cologuard or a FIT test, it can be really nerve-wracking, very anxiety-producing, because you have to wait for your colonoscopy to know, really what's next. And in some cases with that Cologuard, it might really only be because it's a false positive test. And a Cologuard is more expensive than the FIT test. But I want to also reassure you that because of the Affordable Care Act, all colorectal cancer screening is paid for should be covered by your insurance for colon cancer screening. And so you need to talk to your doctor about which test is going to be best for you. So which test is best? And I think my friend and colleague Sid Winauer says it best. It's not the test that the doctor says you have to have. If the doctor tells you only can have a colonoscopy, or what you hear on TV about a Cologuard, the best test is the one that gets done, and the one that gets done well. So it's really important that if you choose a FIT test, that you're going to have your FIT test and you're going to do it every single year. Women, it's like having your mammogram. If you have a mammogram and you wait for 5 years, it's stuck doing what it's supposed to be doing. So if you're going to choose to have that stool-based test, do the FIT every year, do the Cologuard every 3 years, or do your colonoscopy every 10 years. All right, so here's the other thing I hear about screening. People tell me all the time, nobody in my family has colon cancer, so that must mean that I have a very low risk of developing colon cancer. But that's not true, because the vast majority of colon cancers, probably 90% of colon cancers, are not genetic. It doesn't run in families. About 90% of colon cancers are what we call sporadic, and they happen predominantly because of aging, but because of a number of other risk factors that we'll talk about here. So here are the risk factors that colon cancer that I think are really, really important to you. So obviously on the bottom, these non-modifiable risk factors, these things that we can't do anything about, are things that are important, but aging is definitely a risk factor. We see that colon cancer most often happens in people over the age of 55. If you've ever had a history of polyps in the past before, you're going to have a higher chance of having more polyps. If you have a genetic syndrome like familial polyposis or Lynch syndrome, which predisposes you to more colon cancer, that's the case. Race and ethnicity is also really important. We know that African Americans have the highest incidence of colon cancer, the highest chance of getting colon cancer. When African Americans are diagnosed with colon cancer, they're often diagnosed at a late stage, and more African Americans die from colon cancer. Diabetes is also a risk factor, as well as inflammatory bowel disease, and anybody who's gotten pelvic radiation. So if you had pelvic radiation for prostate cancer in men, or if you ever had childhood radiation for, say, Hodgkin's disease, your risk of developing colon cancer is also increased. But I think because we're ACAC, I want to talk about the modifiable risk factors, because by exercising, really, you guys are making a big difference in decreasing your risk of colon cancer. We know that keeping your weight down and preventing obesity, and by exercising, physical activity makes a big difference in lowering one's risk factor for colon cancer. Diet is also super important. We know that the big risk factors for colon cancer diet-wise are red meat and processed meat and alcohol. And I think that's something that the alcohol is the thing that we don't think about very often. Most of us are pretty good about avoiding a lot of red meat and bacon and processed meats, right? And we hear about that. We know that that's not necessarily healthy, but I really want to promote to you also that, especially during COVID times, we've seen a marked increase in the alcohol usage in in our country. We already had a pretty significant issue with many people drinking, and it is a graduated amount that the more alcohol you drink, but actually alcohol in general is a carcinogen, and so it increases your risk, particularly of all GI cancers, esophageal cancer, colon cancer, pancreatic cancer. And I want you to think about your alcohol use because it is a significant risk factor. And smoking is also a risk factor, although many of us know that that's not what we should be doing. And most of us are not smoking because we know it is a real significant carcinogen. All right, so I want to pivot a little bit, and I want to talk to you a little bit about early age onset colon cancer. Many of you know that Chadwick Boseman died from colon cancer at the age of 43. He is a very gifted young actor who starred in Black Panther, and he was diagnosed with colon cancer at the age of 39. The very first year he was introduced as Black Panther. And what we're seeing over time is that there is in really 40 to 49-year-olds, but it's 25 to 49-year-olds, an increase in colon cancer. So I showed you this graph on the left, right? This is our Medicare population. In 60 to 65-year-olds, from the year 2000 on, we've seen about a halving of our colon cancer incidence. But in younger people, we're seeing that colon cancer increases. Now, it's not increasing fast. It's increasing pretty slowly, but and the total numbers are very different. So truly the vast majority of colon cancers happen in 65-plus-year-olds. So we're seeing that, probably 80 to 85% of colon cancers happen in older people over the age of 55. But the fact that these colon cancers are slowly creeping up in young people is causing a lot of concern. So here's the data, and this comes from the American Cancer Society. And basically, what we see is that about 1 in every 10 colon cancers is in somebody under the age of 50. So we're seeing this increase predominantly in Gen Xers and millennials. And for most of us who are older on this call, this means that our children have a much higher risk of colon cancer than we do. You can see here that in the slides here, if we look at young people's colon cancers, what we're seeing is it's more common in the left side of the colon. So it's more common in the rectum, and it's more common in the left colon. So these young people are more likely to present with symptoms, right? They're more likely to have rectal bleeding or difficulty having bowel movements. We're also seeing that these young cancers are happening in very healthy populations, in people who, may not necessarily be obese. And we're also seeing that these young cancers are happening more often in young men and young Caucasian men. So important for you to see this. And it doesn't mean that it's not happening in young women, because it is, but the young men are the population we're seeing it most in. So what's the cause of early onset colon cancer? I think there's a number of different causes, just like there's a number of different causes in colon cancer in older people. But the things I want you to think about, colon cancer in young people tends to be very, very aggressive. It's a very aggressive cancer. These young people who get this cancer are often diagnosed at a very advanced stage, and they often have a very poor prognosis. They die of their colon cancers. What we're seeing in these young people is that some of it's obesity, some of it's other common causes that we have, but about 30 to 40% of these young people, it tends to be more genetic, meaning that their parents might have had a colon cancer, or their parents might have had a colon polyp. And it's not just any polyp, it's an advanced polyp. I think that's important for me to distinguish that if you as a parent have a polyp that's greater than 10 millimeters, which is what we call an advanced polyp, that you need to make sure that your children get screened earlier. At the age of 40 is when we start screening these younger people. The other reason that young people get colon cancer is also because of things like foods and additives and preservatives and chemicals. If I remember growing up, when I grew up, we ate food. We didn't eat a lot of processed food, and we didn't have a lot of chemicals around. There wasn't a lot of things in fertilizers and pesticides being used. And so our foods contain a lot of chemicals at this day and age. And I think a lot of people are looking at chemicals as a possibility. In addition, the microbiome is also going to be an incredibly important part here, because we know that antibiotics, particularly beginning in the 1980s and 90s, have been overused. In our children's generation, we're seeing that many of our kids got multiple rounds of antibiotics for ear infections or even viral infections where they might not have needed it. So that changes the gut microbiome, and that can change the gut bacteria for life. And so it's thought that maybe some of these changes in gut microbiome can also play a role in young people developing colon cancer. So it doesn't matter how old you are. This comes from the Colorectal Cancer Alliance, and you can see it is absolutely tragic. These are young people who develop colon cancer. And so the key message here is it's not going to be useful for us to start screening 25-year-olds. I know that seems intuitive, like, well, maybe we should do that. But really, because the numbers of young people developing colon cancer is low still, it's rising, but it's low. Screening this huge population is, one, not going to be cost effective, and it's also probably not going to be helpful. The most important thing is that if a young person under the age of 50 has alarm symptoms, particularly rectal bleeding or difficulty passing stools, they need to have a colonoscopy. So it's important that if a young person comes in and says, I have rectal bleeding, that you or their family doctor doesn't say, oh, it's just hemorrhoids, don't worry about it, it's going to go away. Because especially if it's persistent passage of blood, having a colonoscopy is really, really important. All right, so I wanted to tell you about what's just a couple more slides. What is the future of colon cancer screening? Because the future of colon cancer screening is definitely not colonoscopy. Colonoscopy will still always be a part, because screening will become more non-invasive, but if a test is positive, right, we have colonoscopy to help us to take these polyps out. So colonoscopy is going to become much more diagnostic rather than just being a screening test. So this is a really cool thing that I found, that there's going to be people are looking into the possibility of doing breath tests for colon cancer screening. So what they were able to find is that dogs have an incredible sense of smell. So dogs could actually, in sniffing the breath of colon cancer patients, they could actually detect which patients had colon cancer just by smelling your breath. What they found is what is in the breath or what is in the stool of these patients who have colon cancer. They have these things that are called volatile organic compounds, things that are actually expelled in our breath. And many diseases, like colon cancer, have these volatile VOC signatures. So colon cancer has a specific VOC signature. So they were able to figure out what chemicals, by gas chromatography and mass spectrometry, what chemicals were in this VOC signature. And they're thinking about actually doing some tests to see whether or not breath testing could be useful as a screening test. So something that may be up and coming, it would be great, because if you could breathe into a little balloon and then have that be your colon cancer screening, it'd be way even better than going home and collecting stool samples, right? Or having a colonoscopy. But I think that's probably not going to be the way things go. I think probably it's more likely to be one of these two. Probably even not less likely to be a pill cam. You know, right now you can swallow a pill and it can take pictures of your colon. It used to be, you know, even 5 years ago that we had this pill cam and it was possible, but you still had to take the prep. And for many people, the worst part of a colonoscopy is taking the prep. And so if you had to take the prep in order for this camera to see things, then it would be, you know, still not as great of a test. Nowadays, this camera is associated with x-rays, and so it can actually almost take an x-ray of your gut as it goes through. This is being developed in Israel. And so I think this is an up and coming possibility for colon cancer screening in the future. Again, this is going to have a harder time, though, finding those flat polyps, right? Because they are very difficult to see. And even if you have x-rays, which is like similar to a CAT scan, it's going to be difficult to see these flatter polyps. I think much more likely what we're going to see for colon cancer is this thing that's called liquid biopsy, which is basically a blood test. As I told you earlier, many of these colon cancers shed DNA into the stool, but they also shed DNA into the blood. And so what a number of people are able to do now, and it's just really ramping up this research here, is that we're able to find these minute amounts of colon cancer DNA in the blood, and then able to amplify them and to say, look, you have colon cancer and it's in a blood test. So I would predict that probably in the future, maybe beyond my career time, but maybe in the next decade, we might be able to go to our family doctor, our primary care physician, and get our cholesterol checked and also our colon cancer screening really done by a blood test. All right, so I've talked a lot. I really just want to make sure that you understand that colon cancer screening saves lives, and to remind you that colon cancer begins as these small polyps. So screening in any form, stool tests, colonoscopy, breath tests, blood tests, ultimately will detect polyps. We'll get a colonoscopy, and by removing these polyps, we can prevent somebody from developing colon cancer. So average risk people should start at age 45 now. So if you are currently 55 and haven't had your colonoscopy, you're 10 years behind, so get on it. FIT, Cologuard, colonoscopy, which one is best? The best test is the one that gets done. And also if you have anybody who has young under the age of 50 who has any symptoms, particularly rectal bleeding, they should have a colonoscopy. So really want to thank you for your attention. If you have other questions, this is our website, and we're happy to, it's got a lot of good patient-facing information about colon cancer screening, and I'm also happy to answer any questions for you as well. So thanks for your attention. I'm going to stop my screen sharing. Is it true? Okay, so I'm going to answer some of these questions. Is that okay, Angela? I can see the chat. All right, so is it true that red blood in the stool is okay? And the answer is no. I hope I answered that for you really clearly, that that is not the case. That, you know, if you have a rectal cancer and it's at the very bottom of the colon, it's gonna present with red blood in the stool. So if you have blood in your stool, you should have a colonoscopy. Now, like I told you, from the onset of a colon polyp to the formation of a cancer takes a really long time, takes a decade. So if you had a colonoscopy last year or 2 years ago, and your doctor told you you had hemorrhoids and you have blood in your stool, you're probably fine. And you probably don't need to have another colonoscopy every time you have blood in your stool. It's that person who is 55 and has blood in their stool and never got it checked out, or that 35-year-old who continues to have blood in their stool and has never had anything checked to have that checked out. Yeah, they need to have that checked out, and it's important that they get it checked out with a colonoscopy. Okay, so another one, is constipation associated with colon cancer? You might think so, right? Because you might think that stool sitting in the colon for a longer period of time is a carcinogen, but the answer is no. There's absolutely no bearing between constipation and colon cancer. May make your prep a little bit harder if you're having a colonoscopy, right? Because it means that you've got to get a lot more stool out, or it might take a little bit longer to get the stool out. But it doesn't increase your risk of colon cancer. Okay, let me come back to the chat here and see what else things. Are disease-carrying VOC? No. Are disease-carrying VOCs contagious? Is colon cancer contagious? Absolutely not. This is not spewing cells. This is spewing chemicals. It's like these things give off chemicals. So no, it's absolutely zero chance of you getting colon cancer spread. Good question though. Does the FIT test separate cancer versus other reasons for blood in the stool? And the answer is no. And so that can be an issue, right? So if you have a hemorrhoid and you get a FIT test, you can have a positive FIT test. That can happen. If you have a hemorrhoid and you have a Cologuard test, because Cologuard tests for blood and DNA in the stool, you could have a positive test. So if you have regular bleeding from a hemorrhoid, you know, you probably should have a colonoscopy, or you may think about doing a colonoscopy instead if you can actually see blood in your stools. All right, let me get back to the chat here.
There was another question. What percentage of polyps generally turn malignant over time?
Yeah, great question. I'm sorry that I didn't answer that. So not every polyp turns into cancer. That's really important to tell you. So many of you guys have come and had colonoscopies and had small little polyps. We consider these to be low risk polyps. We have enough data now from 1990 on to show that if you have one or two small little low risk polyps, your risk of colon cancer is probably, it's there, but it's probably not as high as somebody who develops a bigger colon polyp. So only about 10% of colon polyps turn into colon cancer, 10%, but it's the bigger ones that do, these advanced polyps. So if you have these small polyps right now, and you come and you have a colonoscopy and you have one or two small polyps, our current guidelines are that you don't have to come back for another colonoscopy for 7 to 10 years, because we know that your risk is probably not as high. Many of you who have had colonoscopies with me, and some of you on this call probably are those people who have had bigger polyps. And if you have a bigger polyp, you're going to have to come see me more often. We're going to be friends more often. You're going to see me between 1 and 3 and 5 years, oftentimes between 1 and 3 years to have a colonoscopy, because you're going to be more prone to developing colon polyps. You're more prone to developing colon cancer. And so we want to just take these polyps off before we develop colon cancer. Okay, so here's another one. I'm 29 years old and have been battling obesity, metabolic syndrome, and inflammation for a while now, beginning to lose some real weight. Should I get tested? I'm a young Caucasian male. No. So that, those are risk factors in the same way that obesity is a risk factor for a lot of different cancers, like pancreatic cancer, but it doesn't mean that we test for these things. It means that you're doing the right thing by joining ACAC, right? It means you're doing the right thing by exercising, by eating right, by trying to lose that weight. Those are all going to decrease your risk factors in general, decrease your cardiac risk factors and for the most part as well. And but if you should develop symptoms, if you should develop blood in your stools, then you should definitely get tested. And when you are 45, at the youngest age, you should definitely get screened. So make sure, because you are going to be the person that is, if you continue to have those issues or diabetes, you're going to be the person that has a higher risk. So you want to be checked early on. All right, let's see what else. The increase of alcohol use in the younger population resulted in a greater than 50% increase in cirrhosis of the liver. Rapid growth of wineries, breweries, and distilleries in Virginia, although good for business, is not good for health. As this is a risk factor for colon cancer, would a cancer warning be warranted on alcohol products? Oh my gosh, Eric, if you can make that happen, I am like with you completely. I can't tell you the other thing about this, not only the rapid growth of wineries, I mean, wineries are now considered to be fun places for people to take their children on weekends too, right? We take our kids to go hang out at wineries on weekends, they play and we drink. I'm not saying it's a bad thing. I'm just saying that everything has to be in moderation. But the other big thing that I think about is really important is for you to look at the size of your wine glasses, guys. Because when the FDA or the CDC made their recommendations about what is a safe amount of wine to drink, it was 4 to 6 ounces. These wine glasses were these tiny wine glasses. But if we look at the wine glasses that we have today, they are huge. And we might think we're drinking a glass of wine a day, but compared to what is actually considered to be the wine that's a safe amount of wine, we're drinking way beyond that. So what's the safe amount of wine? It's actually 0. The current guidelines now is no alcohol. It used to be that 1 glass of wine for a woman and 2 glasses for a man was the safe amount of alcohol to drink. And that's really because of the fact that women, we lack this enzyme in our stomach called alcohol dehydrogenase. So we're more prone to developing complications from alcohol than men are. It's not just weight-based. It really is because we lack an enzyme. So Eric, I'm on board. If you want to work on getting in that warning, working on somebody getting a warning, I will help you do that. What symptoms should we be concerned with between colonoscopies? I guess I'm really not sure what the question is. Like, and I guess the answer is, the question is, if you had a colonoscopy 5 years ago and you're not due for another colonoscopy now for another 5 years, but now you're having abdominal pain or bloating. I mean, I think if it's a persistent problem, I mean, I think you should always talk to your doctor about those things that are happening to you. Many times these are not necessarily due to colon cancer for sure, right? Because you've had a colonoscopy. I will tell you that there's a lot of good data that people who have had 2 high quality normal colonoscopies in their lifetime probably have a very low risk of developing colon cancer. What was the reason one stool test gets repeated in 3 years and the other 1 time? Okay, so Shawnee's asking, what's the reason that a FIT test is every year and a stool DNA test is every 3 years? You know, it's because, I think predominantly, Shawnee, it's because of expense, because the stool DNA test is pretty expensive. I have a feeling there's a move to actually getting the stool DNA test to become on a more annual basis. And it's also because it tends to be a more specific test. I mean, it's more, if it's positive, it's more likely to be a cancer or an advanced polyp. So doing those tests, it doesn't have to be done on an annual basis. I think there may be a move to be doing Cologuards more often. I will tell you, your insurance company will not pay for a Cologuard more often than every 3 years. So if you have one done this year, because that's what the United States Preventive Services Task Force recommends, that's what insurances and Medicare pays for. So because the task force says every 3 years, if you decide that you want to have a Cologuard in 2 years or next year, you're going to have to pay for that out of pocket. It's not going to come through the Affordable Care Act. You don't get to get screened more often just because you want it done. It really is based on guidelines, and guidelines are put there for a good reason.
Someone did ask, is chronic constipation associated to colon cancer?
Yeah, and I didn't answer that, but it is not.
Oh, I'm sorry.
Yeah, no worries. Good to reiterate again. Just because you're constipated doesn't mean you have a higher risk of colon cancer, not at all. Yeah.
I have a question.
Yeah.
If you are prone to hemorrhoids, is there any connection to an increase in colon cancer, colon rectum cancer?
So, Angela, no, absolutely not. It has no risk. But I will tell you that people always say to me when they come to their colonoscopy, just, I want to warn you that I have hemorrhoids. And I want to reassure all of you women out there that if you've had a baby or if you're a little overweight, we all have hemorrhoids. It's super common. We don't talk about it at cocktail parties, but it definitely is something that's out there. So don't worry, you're not the only person suffering, for sure.
There's one more. It looks like Carlton had a question. Does the FIT test separate out cancer versus other reasons for blood in the stool?
Yeah. So that's the same thing. So it is that these can check for polyps or cancer, but also if you have a FIT test and you have a hemorrhoid that's bleeding, that's going to be positive as well. So it is a possibility, but for most of us, if you have blood in your stool, you should probably get it checked out for sure, regardless of the reason. Thanks, Eric.
I second that.
Yeah, no. Staying far away from politics. I have this passion for colon cancer screening. My goal is nobody in Charlottesville or Albemarle County gets colon cancer. I mean, I think I think the really important thing about this, guys, who all of you guys are on the call, is you make a difference because you can get out there and spread the word too. And that's why I do this. And this is why I give these kinds of talks, is because you are my messengers to make sure that your husbands, your wives, your children are getting the message out there that screening can save lives. You can do it. And it's really, if we could do this every 10 years, not a big deal.
All right. Gotta go. Thank you, doctor.
You're welcome.
Yeah.
Very much.
All right, all. Well, I think we'll end, Angela. Thank you so much,
Thank
every guys, for
you.
giving me this forum. I look forward to seeing you guys all at ACAC. Keep exercising. We can drop our colon cancer rates.
Thanks so much. That was great.
Yeah, take care.
Thank
Bye.
you all.
Bye.